So welcome to this panel on leveraging new data to measure and address racial disparities. We have three wonderful speakers with us today. Marisa Shenk from Mathematica, Michael Stepner from the University of Toronto, and Michael Collins from the University of Wisconsin-Madison. So Marisa will be kicking us off. Floor is yours.
Great, thank you, James. All right, can you see my slides? Great. So my name is Marisa Shenk. I'm presenting work today on racial disparities and COVID-19 experiences among older adults with disabling conditions. This is joint work with my co-authors Amal, Harrati, Bernadette, Hicks, and Anna Quiñones. My thanks to SSA for funding this important work and to the RDRC for inviting us to share our findings. And here's our usual disclaimer. So more than 2 years into the COVID-19 pandemic, we're still learning about the impacts it has had on different communities. Older adults have experienced particularly high rates of COVID-19 hospitalizations and fatalities. Racial and ethnic minorities, as well as people living in communities with low incomes, were exposed to the virus earlier and faced negative health and economic effects. Early research has shown that people at the intersection of one or more of these identities may be more susceptible to negative effects as well. For example, people with disabilities who are non-white or with household incomes below the poverty level are significantly overrepresented in counties with higher COVID-19 incidence compared to other people with disabilities. However, we know little about the COVID-19 related experiences of people with disabilities. This group is more likely to have an underlying health problem, delay or forego needed medical care, live in a congregate care setting, and rely on assistance with personal care and practicing routine preventative measures. And even less is known about how social factors may compound individual health to result in unequal burdens of this pandemic. So in light of this emerging evidence, we sought to understand the effects of COVID-19 on people with disabilities of varying intersectional identities. Our work documents the negative health, work, and financial experiences of older adults due to the pandemic and explores the intersectionality of race and ethnicity with disability. We also examine the role of contextual county-level factors in driving these disparities. Our primary source of data is the Health and Retirement Study. In 2020, the HRS added a COVID-19 module asking respondents about health, financial, and work impacts of the pandemic. All of the outcomes we examined were measured in about the first year of the pandemic, between May 2020 and May 2021. We also examined data from previous waves of the survey from 1992 to 2018. We used this data to examine demographic information about our sample from prior to the pandemic, such as disabling conditions and work status. The HRS is also geocoded at the county level, which we used for the second major component of our analysis. We gathered county level data from various public sources, which I'll note when we turn to that analysis. So our sample includes adults age 50 and older, who we're calling older adults. We counted respondents as having a disabling condition if they had ever required assistance with an activity of daily living, an ADL, or an instrumental activity of daily living, or IADL. These include things like bathing, dressing, walking across a room, using a telephone, shopping, and preparing meals. In our full manuscript, we also examined results by whether respondents had a self-reported work-limiting condition or had ever received supplemental security income or disability insurance benefits. We used the ADL or IADL definition to be consistent in how we measure disability and include all ages over 50 in our sample. And we included 4 mutually exclusive subgroups of race and ethnicity, including non-Hispanic white, non-Hispanic Black, non-Hispanic person of another race, and Hispanic or Latino. Now I'm going to share our findings. Our results today are adjusted for individual characteristics, including age, gender, and prior health conditions. So I'll start with our health impacts. The survey measured some outcomes related to COVID, self-reported COVID diagnosis or hospitalizations. Given the timing of the survey, we did not find those outcomes particularly meaningful, since some respondents were surveyed early in the pandemic, so they are less likely to have been tested or to answer questions about COVID health outcomes. Respondents were asked whether there were any times since March 2020 that they needed medical or dental care, but delayed getting it, or did not get it at all. So we are going to be focusing on delays in healthcare receipt. Older adults with disabilities were more likely to delay needed healthcare compared to those without disabilities, And some of those differences persisted across race as well. About a third of older adults reported delaying healthcare. Non-Hispanic older adults of another race had a higher rate, while Hispanic older adults had a lower rate. More older adults with disabilities delayed healthcare compared to those without a disability. And the differences across those with and without disabilities and the distribution across race were statistically significant. Respondents were asked why they delayed or did not get healthcare, and they could indicate multiple responses. More than half of older adults who delayed healthcare reported that the clinic, hospital, or doctor's office canceled, closed, or had suggested rescheduling. Older adults with disabilities were more likely to report that they delayed healthcare because they could not afford it compared to those without disabilities. And they were less likely to report that the doctor's office canceled or that they had just decided to wait. Within each race and ethnicity subgroup, we examined the differences between people with and without disabilities. There were significant differences within each race and ethnicity group, and the largest of these differences was within non-Hispanic older adults of another race. Those who delayed healthcare were asked what type of care they delayed, and they could answer with multiple responses. Many older adults delayed dental care and doctor visits, and a sizable group delayed surgery or prescriptions. There were no significant differences between those with and without disabling conditions when it came to doctor or dental care, but there were differences in the other responses. And there were also differences in all of the responses by race. Now we're going to turn to financial outcomes. More older adults with disabling conditions reported financial hardships compared to those without a disability. There were differences across race, both overall and within those with disabling conditions, and the differences were largest among those who were Hispanic or Black. Buying or accessing food were common hardships. We also examined whether income increased or decreased because of the pandemic, but we did not find any differences by disability. About a third of older adults reported any financial hardships during the pandemic. 40% of those with a disabling condition reported hardships compared to about a quarter of those without a disabling condition. And there were statistically significant differences across race as well. White older adults were the least likely to experience financial hardships. Within race and ethnicity subgroups, the differences between those with and without disabilities were large across all of the groups. They were largest among Black and Hispanic older adults, indicating an intersectional disparity there. Respondents reported many types of financial hardships. 16% of older adults reported that they had trouble buying food, even though they had the money, and 9% of older adults reported that they did not have enough money to buy food. There were significant differences by disability and by race. And we found an intersectional effect where Black and Hispanic older adults with disabilities were the most likely to report most of these hardships. And the final domain we examined was work outcomes. Fewer older adults with disabilities were working compared to those without disabilities, and we found fewer impacts in this domain. Among working older adults, about 40% reported effects on work due to the coronavirus pandemic, and more older adults with disabilities who reported work effects said that they stopped working compared to those without disabilities. We found some intersectional effects here as well. For example, fewer Black older adults with disabilities moved to remote work compared to those without disabilities, while the reverse was true for Hispanic older adults. Those with disabilities were more likely to move to remote work. So I'm going to turn now to the role of contextual factors in explaining some of these outcomes. We examined 8 measures of county-level data related to COVID risk, socioeconomic characteristics, healthcare access, and employment. Our measures include, for example, COVID cases per capita, racial segregation, hospital bed capacity, and percent of people receiving government assistance by county. We gathered all of this data at the county level from sources including the American Community Survey and the county health rankings. We found that older adults with disabilities were more likely to live in counties with higher COVID case counts, higher pandemic and social vulnerability, and higher unemployment rates compared to those without disabilities. These differences also persisted across race. In our models, we did not see a consistent pattern of association between contextual factors and individual experiences with delayed healthcare or work being affected. one of the contextual factors we examined did have a statistically significant relationship with experiencing a financial hardship. In our multi-level models, we found that individual level race and disability remained highly significant, even after accounting for the contextual factors. So we think this research leads to 3 policy implications. First, our work highlights the importance of a robust, disability-inclusive public health response. We found that the COVID-19 pandemic had disparate impacts on the healthcare, financial, and work experiences of older adults by disability and race and ethnicity. The vulnerability of this community suggests that they may be similarly impacted by future public health events, such as future pandemics or natural disasters, and that the response needs to focus on the well-being of people with disabilities. We also found evidence that suggests that the intersectionality lens is really important, as older adults with intersecting identities of disability and marginalized race or ethnicity were more likely to have been negatively impacted by the pandemic. And finally, because financial impacts were so widespread and there were intersectional disparate effects on many types of financial hardships, policies mitigating financial impacts may be universally beneficial to older adults, regardless of their other identities. And that's it. I look forward to our discussion. Thank you.
Thank you, Marisa. Is Michael Collins.
Great. Thanks, everybody. Thanks for sticking with us today. So now we're going to talk not necessarily about the pandemic necessarily, but about some unique data that we have in Wisconsin to try to understand the effect of SSA programs on particularly families that we define as being 3-generation or grandparent families. So the standard disclaimer applies. I'll also say in these data, we're working with data from the state of Wisconsin. So all of this is on the backs of the authors and not the funder nor the agencies with the data. All right, so the data we're talking about is from the Institute for Research on Poverty. IRP works with state agencies across Wisconsin, and there's a database that it's actually administrative data that pulls in from different parts of state agencies and programs called CARES, the Client Assistance for Reemployment and Economic Support Systems. So the CARES data draw in from, we're going to look at primarily 3 different agencies: the Department of Health Services, Children and Families, and Workforce Development. So that's going to get us things like food share or SNAP. It's going to get us TANF and or W-2 and the caretaker subsidy for caretaker supplement for people on SSI, as well as child support and child care subsidies. And then from workforce development, we're going to get things like unemployment insurance, but importantly, we're going to get the wage records too. So any payroll income that people have that's reported to the system, we'll get to see that. Plus, we'll get to see all the benefits that they have. So our study is really on these CARES populations. It's not all people in Wisconsin, but we're starting with the premise of people who are in the CARES system. So the CARES system data we're going to look at is from 2010 to 2019, so about 10 years worth of data. And we're pulling people, so we're calling them primary persons. You can think about these as sort of households who are at the same address. And we're identifying those where there is a minor in the house, somebody under age 18. So you have a primary person, at least a primary person, and a minor in the house. And that sort of is what you can think about as being in the all population. So these are people who have applied for food assistance, or they're in some program, or they've applied for a program, or they're in some way engaged with one of these state agencies. But from that, we can construct a household and then tell in the household if someone in the household is designated as a grandparent, and then they have a minor child that they're taking care of. There's no in-between adult, right? It's just the grandparent and the child. So that's only about 2%, 1.8% of our all sample, but we're calling these grandparent households. And then we also have these 3-generation households. So that means that you have a minor child, a primary person, and then their parent. So we have 3 generations in one household, and that's about 7.3% of our all households. So these are all very low income people. It's about 400,000 households. You can think about it that way. We're looking at these case year pairs. So it's like a repeated cross section each year from 2011 through 2019. There are some cases where we have people who are in multiple households in a year, and we kind of split them, based on which household they're in. They might get split between 2 or 3 different households. There's definitely a lot of mobility within these groups. But still, we have a pretty good cross-section in each year of where people are at. Now, the thing we're going to focus most on is the income. So what is the income being reported into this household? So for any of these means tested programs, people have to report all their income levels, and those income levels are then verified by the state, oftentimes with other administrative data. So we have pretty accurate, at least in terms of the administrative data, data on what's available. So we have wages, so everybody who reports to the DUI system. We have child support. We have the unemployment compensation if they get unemployment. We have the caretaker supplement. So this is a supplement to SSI for parents. We have SNAP or food assistance, we have Medicaid, child care subsidies, TANF, and importantly, we have SSA payments. So we have the old age and survivors, we have SSDI, and we have SSI. And so this is really the important piece, is that we get these data. Now, these are initially self-reported by anybody, the primary person who comes through the care system, but then they're later verified. The state has a data exchange with the Social Security Administration to be able to verify these. So we think we have pretty accurate data on all of these. All right, so the first thing we do is just say, all right, who gets any of these kinds of support? So the blue here are all of these CARES households. So again, CARES are low-income people who are involved in some state agency program who have a kid. And then the grandparent household, it's a grandparent and a kid. And a 3-generation is a grandparent, an adult, and a kid. So we have multiple generations there. So many of these households have wages. Not surprisingly, the grandparent households, about 1/3 of them do not have wages, but still 2/3 do. So everybody else is some form of wage income during the course of the year. And again, this is just a dichotomous 0-1. Did they get any of this income in a given year and during our study period? If you look at all SSA sources of income combined, about 2/3 of grandparent households have some form of SSA income. It could be old age and survivors, it could be SSDI, it could be SSI. And for 3 generations, it's about 42%. That's still about twice the rate in the CARES children or the CARES households overall. So, relative to this larger group, so you can think about a Venn diagram of all CARES families with kids, we have this subset of grandparent and a subset of 3-gen. The 3-gen are more likely to have some SSA income than the all group. Not surprisingly, the grandparent households are the most likely to have OAS, to have old age and survivors. Many of them are probably qualified. They're at ages where they'd be qualified for old age and survivors, or old age at least, and somewhat higher for 3-gen. For SSDI, it's much more common among the grandparent households, but also relatively common, about 1 in 5 of the 3-gen households. SSIs, pretty common. We'll see more of that in a bit, but about 1 in 5 have SSI, meaning this is means tested, so these are pretty low income folks. And then finally, in terms of food share, which is we looked at a lot of different non-SSA support programs, but food share was by far the largest. Probably the main reason that people would be entered into the care system initially is because they were looking for food share or SNAP support. So it's about half the sample who has some sort of food support. So the next thing we want to do is look at the poverty threshold. So we have these, these federal thresholds that designate what the poverty level is. And then we can say what percent of the sample were people who were above or below that poverty threshold. So the overall poverty rate in this care sample is about 50%. So quite high, right? These are low-income people. They are entering the care system because they're seeking out some safety net program. So overall poverty rate about 50%. For the grandparent households, it's slightly lower, 48%. For the 3-gen, it's about the same, about 50%. So this gives you a sense of the overall sample of what the poverty rate looks like for these households. If we look just at where the primary person is white, the poverty rate is only 43%. When the primary person is Black, it's about 61%. And if the primary person is Latina, it's about 67%. So slightly higher, much higher poverty rates for Black and Latina primary person households relative to white households. So the primary exercise we've done here it's fairly reductive in a sense. All we say is, let's look at what those poverty rates would be if we were to subtract out Social Security programs. What if they had no income from Social Security? No OAS, no SSDI, no SSI. And let's see how that would change the relative poverty rate for the particular group of people that we're looking at. So if we start on the left side, the all-child households, You can see the yellow is all SSI. SSI programs reduce the poverty rate to by about 5%. So I told you the overall poverty rate was about 50%. So without SSA programs, it would be 55%. So you can think about these relative reductions. Again, it's totally reductive. Just excluding one category, what would that threshold, what would the share of people meeting that threshold of the poverty rate be? If we look at grandparent households, it's a much larger reduction. SSA programs across the board are reducing the poverty rate about 18%. So poverty rates would be that much higher if not for that SSA. I mean, obviously, we're not holding anything constant here. If people would probably have different behaviors if SSA didn't exist. But in terms of budget share, this is an important part of their supports. Old age is a big part of what's supporting grandparents, old age survivors, SSDI to a slightly lesser extent, and then SSI about 3 percentage points. For the 3-gen household, it's not quite as large as what we see for the grandparent households. It's about 8% reduction in poverty rates with the all SSA programs. Much of that's coming actually from SSDI. So these 3-generation households look a little different. You have perhaps it's that parent, that middle-aged person who's not in older age, who's has a disability and might be on SSDI. So we have a slightly different pattern in terms of what we see from income supports in these families. Then if we turn to by race, so again, these are all CARES families with minors. We have an overall reduction from SSA programs among where the primary person is white of about 5%, 4.7%. Where the primary person is Black, it's about 7 percentage points. And then primary person Latina, it's about 2.5 percentage points. So pretty big differences by race with particularly larger reductions in the overall rates of poverty among a primary person being Black. SSI plays a really important role for the primary person Black households. It's about 4 percentage points reduction in the poverty rate. So these means tested benefits are particularly important for that group. We see a similar pattern in terms of the Latina group, but it's just a much smaller magnitude. And it's actually the opposite for the primary person white households. The smallest contribution is from SSI versus OAS or SSDI. Now, all this does is combine the two together. So we look at grandparents and race and 3-gen and race, and you can kind of see pretty similar. I mean, it is literally just putting together the two patterns we just shared. So a pretty big effect of SSA programs among grandparents who are white, fairly similar size, but a little bit smaller for grandparents who are Black, and quite a bit smaller for Latinas, grandparents who are Latina. Among the 3-gen group, we see larger effects actually among the 3-gen Black primary person households, a bit smaller for Latina, and then for white, sort of in between. Again, the SSI, the gray bar, is particularly large for the means tested program, is particularly large for the 3-gen Black. We didn't quite see the same pattern with the grandparent Black. That tended to be more the OAS. So lots of interesting patterns here that maybe we can talk more about in discussion as well. So overall, what are we seeing in these data? So this is definitely a descriptive exercise, but what we find, given this population, we think is pretty interesting. About 2/3 of grandparent households are getting some Social Security support, and about half of 3-generation households in these data are getting Social Security support. The poverty rates are lower when we count in these SSA programs, not a surprise, but by 18 points. For the grandparent households, about 8 points for the 3-generation households. So it's a pretty significant reduction in poverty. We see a big effect of SSI, especially for Black households. And Latina households, as in the very beginning, I said they have one of the highest poverty rates and also some of the smaller reductions in poverty from the SSA programs. So this probably has some implications for how we think about program coordination across different kinds of, so whether it's child support or foster care. We also need to think about these unusual household structures of grandparents and 3-gen. They're relatively small, but when we think about the deeming roles or redetermination in SSI, these various household structures might be particularly important for households of color to think about. So just overall, this is a relatively small but pretty financially vulnerable population. So we think the grandparent and 3-generation households continue to be an area of importance to study. I think we could probably do more to understand these multiple programs, the state supplements, SNAP, and just try to understand how these different programs work. And then we see some key differences between the means tested versus the more work-based programs. And then finally, I think this is an example of how you can use administrative data to look at some focal populations that are hard to study in other surveys. So at least this can be an example in that regard. I'll stop there. Thank you.
Thank you. Please feel free to type questions into the Q&A box, and we'll kind of select among those that are said. There is one question from before for Marisa. Can you think of explanations why the disparities between people with and without disabilities were highest among people of other race when it came to delays in medical care, but highest among Black older adults when it comes to financial hardship?
Yeah, thanks for that question. I think that this is pure speculation, but I think that there are different kinds of disparities that we have experienced in this country for historical reasons that could lead to different types of outcomes. So for particularly Black older adults, I think that there's a history of poverty, there's a history of policy implications from housing and many other domains that could contribute to that. And I think that that is some of what we're seeing in that disparity. Whereas for other populations, oh, my lights just turned off. For other populations, it could be coming from different types of policy implications.
Thank you. Question for Michael Collins, I think. Question is, can you clarify again who is in the CARES population, i.e. who is in the denominator of these stats?
Yeah, so the denominator are all households. So again, primary person plus a minor child who in a given year sought out one of the public programs. So they were in SNAP, they applied for, they were in SNAP, they were in one of the child care support programs, they were in one of these other populations. So it skews lower income. We think it's about 2/3 of the total population of households with kids, but obviously much more skewed towards it's the lower income chunk of that because they're involved with the social safety net.
So I have a question for Michael Stepner. So that convergence of Black-white mortality conditional on income was quite striking, and you kind of hinted that you guys were going to be looking at the mechanisms behind that convergence. Any kind of preliminary speculations as to what the leading mechanisms for that might be?
So I do not have preliminary results that I'm withholding from all of you. So my guess is an informed guess, and I'm sure other people have guesses that are just as informed. I would say that the two big buckets that often come to mind are access to healthcare and differences in health behaviors. And what we and other research have historically seen is that access to healthcare explains a very small part of these disparities. And in particular, you would think that access to healthcare is, differential access to healthcare in the United States is often mediated by income. And I don't think that the story we are going to see is that Black Americans suddenly had access to healthcare in 2019 that they didn't have access to 2001 in a way that other racial groups did not. In terms of health behaviors, I don't know what the story might be in that. I think that's something worth unpacking. I think your question relates to a really interesting question that came from Vincent Pohl in the chat about how should we interpret the difference between these two lines, where if you look at the line without conditioning on income and you look at the line conditional on income, and you see convergence on one and massive disparities if you don't condition on income. And I think perhaps more broadly, taking a step back, what I'm excited about these descriptive facts is that they point to, I think they can help inform what sets of policies might be effective in reducing the gaps. I wouldn't declare victory in saying, oh, look, it's all income. The gaps are done, right? That is a form of included variable bias, where if all the disparities are from income, that's where you need to look to address these disparities. It's not about, a story where two people with the same income have very different outcomes. The sorts of policy mechanisms need to focus on those disparities in income and what they imply for health.
Thank you. There's a question from Michael Collins in the Q&A box. Will you be able to add in the effects of the 2021 refundable federal CTC next year?
That's a really good question. We don't really observe the payments that would come through the CTC. However, we could certainly, we could sort of backdoor, we could whatever envelope, figure out what it might be based on what their household type is. So that's a good question. I think we could probably look into that.
Thanks. And just to keep you on the hot seat for a moment, your data are from Wisconsin, which is a wonderful state. Do you think that if we were to look outside Wisconsin, these patterns, is there a particular reason to think that these patterns might be different outside of Wisconsin versus in Wisconsin? Of course, they're not going to be exactly the same, but.
Yeah, you know, it is. If you were, let's say, for example, you were looking at a different state and also look at people who have some engagement with the social safety net, would we see the same patterns with grandparents and three-generation households? I think we probably would. I think what might set Wisconsin apart is that it's a relatively lower cost of living housing cost place. And so I think if you were to look at a place where you had higher cost of living, higher housing costs, you might see even more of these three-generation households, which is simply economies of scale, trying to take advantage of shared housing. So we might see even more cases of these three-generation households or even grandparent households, which are driven by those cost concerns. And I don't know this, but my guess is that they would probably even show even more signs of financial vulnerability with higher poverty rates and potentially even larger relative effects from the Social Security programs that they benefit from.
So you guys have been very efficient in answering questions typing. I'm wondering if there are any questions that you thought were kind of, you wish you could elaborate more on the typing and you have more expansive answer orally, or maybe just questions that you think should be brought to kind of more salience for our audience.
I would add that we'd welcome more questions. If anyone has been sitting on one feeling shy, please be our guest.
So there's a question for Michael, I think Stepner, not Steiner. I think that's a autocorrect typo. So could the differential COVID impacts by race be related to likelihood of work from home / not? Have you given thought to proxy measures in this regard for the gap among younger folks?
Yeah, so this is something that we did study. I did not include this slide in this deck, but the gaps are largely predominantly among the elderly and retired population. And so I do not think that, you see these gaps at every age, but just in terms of mechanisms is much larger among retired people. And so the story you would need to tell for this to be driven by differences in work from home is one about multi-generational families, where you have older Black adults living with younger Black workers who are going to work in person and catching COVID and bringing them home and infecting their parents or their grandparents. Is that plausible? I think it is plausible. I do not think that our data is the data that's best placed to study it, but I think one general question about some of these stories, this sort of toxic contract where the story was like, oh, well, the people who have kept their jobs are perhaps worse off because their jobs have gotten worse, they're not making that much more money, and now they're being exposed to additional COVID risk. I think that is not the primary story that is explaining this increased disparity here. It needs to be something that is going to hit retired households.
Just following up on some of this heterogeneity, you hinted, Michael Stepner, about interesting stories involving other races too that you didn't have time to get into, but we have a little bit of time here. Are you prepared to give a quick summary of what might be going on with other races?
Yeah, so let me highlight one group that I think is particularly interesting to study that our data is able to speak to in a fairly novel way, which is the American Indian or Native American population, where in typical survey data, you just do, the population is too small to pick up a reliable estimate. We know that they are, that Native Americans are disadvantaged on every dimension we can measure, but kind of like zooming in on these sort of precise pictures of how that disadvantage plays out at different income levels is difficult in survey data. And so the admin data lets us actually study the Native American population. And what we see is that the disadvantage is, if you scroll back 20 years to the turn of the 21st century, disadvantages of this similar magnitude to Black Americans, and we do not see this improvement over the last 20 years. So I think that raises a question where certain disadvantaged groups in the United States have, Black Americans have seen tremendous growth in life expectancy over the last 20 years, and that growth has left behind Native Americans. And I do not have a mechanism at this point to tell you as to why that would be, but I think that is a super important question that merits future study.
There's a question from Ellen Mira. Michael, I think Stepner again. In light of improvements in life expectancy, the COVID results are quite striking. What do you know about the cause of death in the pre-COVID period driving the narrowing for higher income Black versus white individuals?
I hope to answer that question perhaps at an RDRC in a year or two. We are working on linking in cause of death data. So right now we're working purely with the SSA mortality records, for which we know the date that someone dies, but we do not know what they died of. Whereas CMS has really excellent cause of death data, and we're trying to bring that into this linkage environment so that we can answer precisely that sort of question.
Question for Michael Collins. Could you clarify again how the SSA data are linked to the CARES database? And she says, I think you said those data are self-reported.
Right. So when somebody comes in, say they're going to apply for SNAP, food assistance, they complete their benefits application form, and they would include all their income sources, and they would put down the amount of SSI or OASI or SSDI that they get. And then we don't know exactly the cadence of the matching process, but the state agency then has a data exchange with Social Security Administration, matches that person's identifying information to verify that income data. So for all the periods that we're examining, that examination would have already occurred. So if the person's self-report was off, it would be corrected, and what we would be observing is what the actual benefit amount was. So it's all part of the administrative data exchange, as part of the income verification and means testing process that the state does.
Is there anything else that any of the panelists want to kind of chime in on, elaborate on? And oh, excuse me, there's another question that's come through. Curious about the role of congregate care settings in the 2020 shift towards wider life expectancy disparities for older adults. Is that something that you've considered?
So I'm going to guess that's for me, and it's something we've considered and something we've tried to measure directly using the geographic data, where there's certain, if you can get small enough in geography, there's certain areas where there's a high concentration of older adults living in congregate care settings, and other just geographic areas where most older adults are living independently. I don't have any results yet on that regard. Our back of the envelope calculations suggest that is at most a partial story. So, I don't think that explains the majority of this growing disparity that we see. But I think for the sort of decisive answer that I would want to give you and that you would probably want to receive, it's more of a stay tuned.
Okay, well, I guess one more time, is there anything else that the panelists want to elaborate on before we maybe wrap up the session? Well, if not, then I'm going to turn it back to Nicole to see if there are any final announcements for today.
Well, thank you, everyone. That was just terrific. And this is the end of day one of our program. I really hope you enjoyed it as much as I did. Please join us right at noon Eastern Time tomorrow. We have an amazing keynote speaker, Dr. Marcella Alsan. She's a physician and an economist and a 2021 MacArthur Fellow. She's done pioneering work on health disparities at the intersection of medicine and economics. I'm really excited. I think you're really going to learn a lot from her lecture. Please use the same Zoom and live stream links that you used today to access the conference tomorrow. And as always, if you have any technical questions or concerns about the materials posted or otherwise, please reach out to Kanza Maham. She's putting her email in the chat right now. And that's it. Have a nice afternoon.